Hi, my name is Dan Maselli, and I'm a GI fellow at the Mayo Clinic in Rochester, Minnesota. On behalf of our contributors, it is a privilege to be able to speak with you today about our recently published article in GIE, Revisional Endoscopic Sleeve Gastroplasty of Laparoscopic Sleeve Gastrectomy in International Multicenter Study. The United States, indeed the world, faces pandemic levels of obesity, and the most effective strategy presently to address this obesity pandemic are bariatric surgeries. The most commonly performed bariatric surgery in the world is the laparoscopic sleeve gastrectomy, or LSG, and this is due to its safety profile and ease of performance. However, because the LSG influences fewer metabolic pathways than, say, the Roux-en-Y gastric bypass, there is a subset of patients who experience weight regain after their LSG. This is estimated to be about 1/10 to just over 1/3 of patients and will typically occur about 5 years after their surgery. Now, to address this, there are revisional surgeries that can be undertaken. However, each of these carries a heightened risk compared to the initial surgery. So what we need right now is a safe and durable and effective technique to address weight recidivism after the LSG that can ideally avoid revisional surgery. Endoscopic bariatric therapies that remodel the stomach have shown considerable promise in the primary treatment of obesity, and because weight regain after the laparoscopic sleeve gastrectomy is often observed in the context of a dilated gastric reservoir, those with expertise in bariatric endoscopy have endeavored to adapt that technique for revision of laparoscopic sleeve gastrectomy and those with an inadequate response or loss of response to that surgery. It's hypothesized that restriction of that reservoir both axially and longitudinally could facilitate weight loss in these patients. While this technique, which we have called the Revisional Endoscopic Sleeve Gastroplasty, or RESG, has been performed at several centers across the world empirically, it has yet to be examined in a systematic, robust fashion. We sought to appraise the RESG through a retrospective analysis of patients who'd undergone the procedure for weight regain after the laparoscopic sleeve gastrectomy. We included consecutive adult subjects at 9 international centers with expertise in bariatric endoscopy. Our primary outcomes were total body weight loss at 6 and 12 months, as well as responder rates. So greater than 10% total body weight loss was considered a good response, and greater than 15% total body weight loss, those were considered super responders. Our cohort was predominantly female. The mean age was about 43 years. These subjects underwent the RESG about 5 years from their laparoscopic sleeve gastrectomy, and the procedure took approximately 48 minutes and used a median of 4 sutures. Total body weight loss was 13.2% at 6 months and 15.7% at 12 months. Responder rates were promising, as greater than 10% total body weight loss was achieved by 81% of the cohort at a year, and greater than 15% total body weight loss, the super responders, were over 50% at 1 year. In terms of safety, no serious adverse events were observed. One patient about 12 days after the procedure experienced some dysphagia, and an upper GI series showed a narrowing at the gastroesophageal junction, and this responded to a single endoscopic dilation. About 5% of patients experienced dehydration that required IV fluids, and 9% experienced new reflux symptoms. We did examine if any patient or procedurally related factors could influence total body weight loss response at 1 year, but no such relationship was observed on our univariable analysis. Our study demonstrated that the RESG is both a safe and effective tool for managing weight regain after laparoscopic sleeve gastrectomy with good midterm durability. Total body weight loss was just about 16% at 1 year, with a good clinical response, meaning greater than a 10% total body weight loss achieved in just over 4 out of every 5 patients at 1 year without any serious adverse events observed. Our study was bolstered by a multi-center international design as well as a reasonably large cohort, though it was limited by loss to follow-up, lack of a control arm, and the heterogeneity of center-specific practices such as suturing pattern. Future study of the RESG should probe questions related to its long-term durability, the optimal suturing technique, as well as its ability to ameliorate return of obesity-associated comorbidities. We thank you for your time and attention to this overview of our study, and we do hope you enjoyed reading it in GIE. Thank you.